Welcome to another episode of Single Payer Radio. We broadcast our program from the Hayburn Building here in downtown Louisville. We are a project of Kentuckians for Single Payer Healthcare, and we're an affiliate of Physicians for a National Health Program, the Kentucky chapter. Our current fragmented care system costs twice as much as in other developed countries and delivers worse outcomes. Tens of thousands of Americans die unnecessarily each year because they can't access care. Over 100 million Americans carry medical debt, often leading to bankruptcy. That's why we advocate for a national, publicly funded, nonprofit, single-payer system. Everybody in, nobody out. The views and opinions expressed on single-payer health care are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. You can live stream us on forwardradio.org. If you miss a show or want to listen again, you can do this at forwardradio.org/singlepayerradio. WFMP is an all-volunteer station. We rely on the community for your ideas and our funding. Join us, forwardradio.org. Doctors Mike Flynn and Gene Shively are back in the studio. Mike?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery.
I'm Eugene Shively. I'm a retired surgeon from Campbellsville, Kentucky. I've been doing rural surgery since my residency. What I say today is my own opinion and not that of Taylor Regional Hospital or the University of Louisville Department of Surgery.
Well, our topic today will be the U.S. healthcare industry as opposed to or compared to the healthcare systems that exist in almost all other first world countries. Our healthcare industry is focused on extracting profit from healthcare activities, whereas the other first world country healthcare systems are focused on providing healthcare to their citizens. There's a lot to talk about. I'm going to begin with a focus on our healthcare system compared with some other healthcare systems. And then Gene is going to begin to talk about the finances of U.S. healthcare, which in my opinion is probably the most important part of this program. And then we'll get into some details and specifics about examples of how healthcare industry functions not to the benefit of our citizens. Before I get started, let me challenge our listeners not to take what we are saying as absolute gospel or truth. Double check our facts. There are a number of good resources where information on the internet and other sources where a listener can decide whether we really got it correct. So let me begin with a very fundamental question. What is healthcare? Is this a commodity like the gas that you put in your car or the groceries you buy at Kroger or wherever you buy your groceries? It allows a for-profit company to make money as profit or pay dividends to investors, or is this an essential public service and a government responsibility? Basically, U.S. healthcare, unfortunately, is an industry focused on allowing an assortment of entities to extract profit from healthcare activities. Healthcare in most other first world countries is a system focused on providing healthcare to their citizens. Let me just take a few moments and discuss some of the other ways that countries do this. The Scandinavian countries, the European Union, Canada, Australia, New Zealand, Singapore, Japan, Taiwan, South Korea, Saudi Arabia, Middle Eastern countries, Dubai, United Arab Emirates, Israel, Turkey, all of these countries have put together systems, usually in some way involved in the management by their central government, providing health care to their citizens. Just let me make a few specific examples of this before I pass this over to Gene. So, United Kingdom, they established the National Health Service in 1948. They run everything: universal health care, physicians' offices, the pharmacies, the hospitals. It is funded by general taxation, and private health insurance is available if a person would choose to have it. Both Canada and Australia both established healthcare systems in 1984. In Canada, it's called Medicare for All. It is taxpayer funded. It covers hospital and physician costs. Private insurance or employer programs are necessary for drugs, dentistry, hearing, sight, other aspects of healthcare. And private health insurance for physician and hospital costs is available if the person would choose to have it. Australia, universal health care, multiple funding sources, and private health insurance is available if a person would choose to have it. Australia has a Department of Rural Health, established a government department to assure that people living in the Australian outback and other rural areas have decent health care. And at some point later on in this program, we'll discuss the unfortunate situation of rural health in this country. A couple more quick examples. Japan established universal coverage in 1961. Multiple funding sources, national, local, employer, employee. There are some out-of-pocket costs. There are no for-profit hospitals. Health insurance is mandatory, and health care fees are regulated. South Korea, 1989, universal national health insurance is compulsory. Multiple funding sources. They levy a 6% tax on tobacco, which partly funds the healthcare system. A last example that I will give is Israel. In 1995, established a universal medical insurance company. You can get increased private health insurance if you choose. Most of these countries provide government-run health insurance and allow the availability of for-profit health insurance or private health insurance if a person should choose to have it. So, Gene, you have done a lot of research on the financial situation in this country. And I think this is probably one of the most important aspects of this program, so I'm going to pass this over to you.
Well, my original intent, and is still my intent, was that there's a huge waste in the U.S. healthcare system, and even though we spend twice as much money as any other country in the world, and our results are not that good, that there's enough waste to pay for a universal health care system. And I'll start off with the total cost of the healthcare system in America is approximately 4.1 trillion, and that's rapidly increasing. Now, I want to give a disclaimer that these numbers are hard to come up with, and they're rapidly changing and probably changing on a day-to-day basis. So I don't want to give you an idea that these numbers are exactly correct, but they give you a ballpark figure. So 4.1 trillion represents approximately 20% of the GNP, which represents the fifth largest economy in the world, and it's projected that that's going to go up to 22% by 2027. And just to show you how much money that is, the Department of Defense spends approximately $800 billion a year, and that's one of the largest expenditure of the federal government. Now, the U.S., as I mentioned, spends twice as much as the rest of the world, and yet our results are we're number 10 for as the countries that are the high-income countries. And the three biggest costs in the U.S. healthcare systems right now is for-profit insurance, which is rapidly increasing. And it's interesting that their profits dramatically increased during the COVID endemic. Now, I want you to understand the difference between for-profit and not-for-profit. I don't think we have very many not-for-profit companies left, but we'll compare it to Blue Cross Blue Shield before they became for-profit. Any excess money that they made went back into decreasing premiums or providing extra medical care, etc. Now, the for-profit companies, the excess money they make goes for administrative charges and for stockholders. Now, I'm not opposed to the capitalist system. Matter of fact, it's the best system in the world. But I am opposed for stockholders making money on sick folks. I don't think that's proper ethically and morally.
Well, capitalism's a good system as long as it's regulated and not
Absolutely.
allowed just to run rampant, which is unfortunately what's going on. Gene, can you put a number? I read somewhere that the for-profit health insurance companies extract something in hundreds of billions of dollars out of healthcare, not being used for healthcare, but used for profit, administrative costs, the CEO salaries. Is that a correct number?
Well, the latest number that I have in 2020, their profit was $23 billion. And it's probably higher than that. Now, the other big cost affecting medical care in the United States is pharmaceuticals, and we are responsible for the cost of half the drugs in the entire world. Now, we do have polypharmacy, but they have the same problem in a lot of other countries. And in Canada, for example, they are able to bid for drugs. In the United States, Medicare cannot do that. As a matter of fact, the law states that we cannot, that Medicare cannot bid for drugs. Now, the VA does, and Medicaid does. And the other big cost is administrative cost. Since 1970, the number of administrators in healthcare has gone up exponentially. The number of doctors has only gradually increased. Now, you ask, why do we need so many administrators? Well, just one example of that is it takes a phenomenal amount of people just to run a doctor's office. For example, each insurance company has got different rules. You got to get pre-authorization, and you'll be on the phone for an hour talking to somebody or trying to get a hold of them for an hour just to get pre-authorizations. Different companies require pre-authorizations for different things, and there's no standardized billing. Now, the per capita spending on drugs in this country, and this is 2021 data, is that it was about $1,300 per person. That's almost double the amount of money that was paid in Canada, and they also have a problem with people taking too many drugs, polypharmacy. One of the other interesting things, which most people don't know about, and is extremely complicated and is almost impossible to figure out, is the drug benefit managers. And what they do and how they do things is kind of top secret. Different companies own their own drug benefit managers. For example, CVS owns their own benefit managers. Different other big companies own their own drug benefit managers. As far as I can tell, the drug benefit managers go and buy drugs from the drug companies, and then they sell it and bid it to different drugstores. For example, you may be able to get a drug cheaper at CVS or at Kroger than another drug company, and it's because of the different bidding that they do for the drugs. Because of loopholes in the patent laws, the drug companies sometimes will take an old drug, repatent it, or change it a little bit, and come out selling it at a much higher rate. For example, just a few days ago, I wrote a prescription for my grandson because he had pink eye, and the drug I chose is a drug that's been around since the 50s, and that it was going to cost $200. Well, that drug should probably be less than $10. But because of these loopholes and because of drug benefit managers, it's very high. Now, the U.S. U.S. administrative system is estimated to cost $812 billion. That means that we spend lots more on administration of things than other countries. For example, in Canada, if you've got an office and a patient has a bill, then they send it to a regional office and they get paid for it. It's not like in this country where if you have a bill, you have to negotiate it with the insurance company, not only private insurance company, but also with Medicare and Medicaid. You have to make multiple phone calls. Often that bill's rejected and you have to refile it. And it takes a huge amount of time for hospitals and for a doctor's office to collect this money, and therefore it takes a lot of people to stay on the phone and stay on the computer.
Yeah, from an administrative standpoint, from the mid-1970s to the mid-2010s, there has been an astonishing over, I'm going to say this again, over 3,000% increase in administrators, to the extent that there are 10 administrators in this country, and this is information from the Bureau of National Statistics, that there are 10 of them to every one of us. And all of the complexities that you're talking about are unfortunately related to the fact we've got all of these people who don't work in the ICU, they don't work in the emergency room, they don't give vaccinations, and they're basically managing the system in this country as profit extractors as much as they are a system that's supposed to be providing health care.
Another example of excess cost in the United States is advertising. It's estimated that the U.S. healthcare system, and that includes doctors, hospitals, and particularly pharmaceuticals, that we spend about $30 billion. We are the only country in the world where healthcare, particularly pharmaceuticals, advertise. New Zealand does allow drug companies to advertise. They're the only other country in the world. It's a total waste of money. Our doctors are smart enough to figure out what drug patient needs, and but the pharmaceutical companies, if you watch TV every night, you notice that some programs, the majority of the advertising is about drugs. And if you look up these drugs, they're very sophisticated and they're very expensive. Now, I'm not trying to say that the pharmaceutical companies hadn't done a fantastic job in developing new drugs. For example, the vaccines for COVID. Who would ever believe that we could essentially cure AIDS, and monoclonal antibodies, et cetera, et cetera. They've done a great job, but they certainly don't need to be advertising it.
Well, they claim, the pharmaceutical industry claims that the expense of many of our drugs is based on the research costs for develop these drugs and manufacture them. In fact, they spend more money on advertising than they spend on research.
Yes, and most of the basic research comes from the federal government. I mean, they contract out with medical schools, et cetera. Well, now there's a huge amount of potential savings. Shall I read all these off or just get to the final number?
Well, tell us how much of the amount of money in healthcare in this country is not used to provide healthcare.
Okay, that is a really interesting number. It's $1,354,000. Now I have to look at. I couldn't sit down and write out that number. I'd have to figure it out. But that's approximately a third of the entire cost of medicine in the United States. Now, I want to emphasize that does not include the entire cost of the U.S. healthcare system. I have never gone back and looked at the cost of EMS, nursing homes, rehab, dental care, home health care, and durable and non-durable medical equipment. And some of that cost is just phenomenal.
Yeah, but that's the reason we have a healthcare industry as opposed to a healthcare system, because that money is going into the pockets of those entities that you mentioned, the for-profit health insurance companies, the pharmaceutical industry, the pharmacy benefit managers, and we haven't even gotten into all of the invasion of private equity into healthcare, which we'll get to eventually. But go ahead, Gene. I apologize for interrupting you.
Well, private equity is an exploding phenomena that we'll need to talk about. It's almost frightening. So the emphasis has evolved in the U.S. healthcare system, essentially from patient care to for-profit, and the system, the for-profit insurance companies, pharmaceuticals, etc., have developed some very good methods of advertising, of marketing, and convincing people that this is all good. Nobody ever mentions that there's the profits that they're making. To give you an example, I'll bet you that most people don't know that the nursing home near them is now an equity company. I just found out about a year and a half ago that one of the nursing homes in Campbellsville is bought out by an equity company. I had no idea. And this is the way most of it's being done. The other interesting thing is a lot of doctors are being bought out by equity companies. For example, since the first of the year, I know of a family practice that sold to an equity company, and there's a large dermatology practice here in Louisville that did the same thing.
Gene, let's kind of go back and start picking each one of these entities and talk a little bit more about them. Let's start with the for-profit health insurance companies. So we have in this country over 1,000. I'm going to say this again: over 1,000 for-profit health insurance companies. Each company has 10, 15, 20 different plans that pay that the client or the patient would buy the insurance. Good insurance costs a lot of money. You can get some really cheap health insurance that really doesn't cover very much at all. So the patient or the client pays a premium to the for-profit health insurance company with the hope or understanding that they're going to get health coverage. And again, the coverage it varies from almost very little coverage to very good coverage, with all of the administrative and other issues from co-pays to networking, to pre-admission, and all of the aspects of being able to actually get the health care. So this premium then goes to administrative costs, advertising, political contributions, executive compensation, which I think we should talk about in a little bit, just because that's astonishing. They invest this money in to make more money, and then the for-profit insurance companies call actually paying their claims a medical loss ratio. The fact that they are paying for the health insurance or the health care that they claim that they are providing is called a loss. So it is a financial loss to this company to pay the claims. And the money that's left over then goes to executive bonuses, investor profits, and all of the other things that don't involve paying health care. Now, one more quick comment about that. Blue Cross and Blue Shield, before it became a for-profit back in 1993, had a 5% administrative cost, and 95% of the money that was paid to Blue Cross and Blue Shield at that time was spent on providing health care. After Blue Cross and Blue Shield became WellPoint for profit, 20 to 35%, depending upon what they could get away with in any particular environment, was administrative costs used with all the issues that I just mentioned a moment ago. And 65 to 80% of it was then spent on health care. Medicare, currently, traditional Medicare, not Medicare Advantage or some of those other issues that we need to talk about, has a 2% administrative costs. 98% of the dollars in traditional Medicare goes to provide health care. And just to have another example, in the country of Taiwan, their administrative costs for their universal health care system costs less than 2%, and more than 98% of the money in the Taiwanese healthcare system is used to provide health care.
Well, not only have the profits and the amount of money going to non-patient care, that's dramatically increased. And right now, just an example, the Advantaged plans, which represents now 50% of all Medicare, most of that money is coming from the federal government, either through Medicare or Social Security, and people are attracted to that. The reason they're attracted, it doesn't cost them very much, and the marketing's outstanding, and they don't have to pay much up front. The problem with the Advantage plans is that it's good coverage up front, but at the tail end, if you get really sick, you got to go to rehab or to a nursing home, then it's really hard to get those paid for.
Well, let's going back to the for-profit health insurance companies. Before Blue Cross and Blue Shield became a for-profit, the CEO made about $500,000 a year, which is not bad. I mean, I think if you make $500,000 a year, you don't have to worry about food stamps, and you can have a nice car and a nice home. Your kids can go to school, and you can take vacations. Let's give you a couple of examples of the kind of money that healthcare CEOs are making. Now, this is back in 2003. The CEO of United Health Group, this is a guy named William McGuire, this was in 2003, made $94 million and change. $94 million and change.
Now, what year was that?
That was 2002. That was a while ago, admittedly. So today, we're going back to 2019. There's a fellow named Alan Miller, who is the CEO of United Healthcare, and his total compensation, he's just not even close to McGuire, is $23 million. Columbia HCA, a fellow named R. Milton Johnson, is making $20 million.
Now, does this include stock options?
This is the whole total compensation. Their stock awards, their salary, their cash pay, their bonuses, their other perks. There's Molina Healthcare, $15 million. So, and this is just the top of the food chain, and the COO, the CFO, all of these other people are making huge amounts of money. The money doesn't come from designing a better running shoe or making a more fuel-efficient automobile. The money comes from the premiums that people are paying with the expectation that they're going to get health care. So again, I think that we just need to have we don't have to spend the whole time on for-profit health insurance companies, but this is really important because all of those other first world countries, while they may allow private insurance, they don't allow the dominance of 1,000 companies running the system the way we do in this country.
It's my understanding there are very few for-profit companies in the rest of the world.
Yes, I agree with that.
I think there are maybe a few for-profit hospitals in Europe that cater to the very wealthy.
Well, it's very clear that the main goal, the mission, or the purpose of a for-profit investor-owned health insurance company is to make and keep as much money as possible. When you think about what they claim, the payment for healthcare services is considered a medical loss ratio. All right. Do we have anything else we want to talk about that, or should we go on to the pharmaceutical industry? It's fun, from the good, bad to the ugly. I mean, let's just talk about a little bit the regulatory environment in this country. You already alluded to that, and I think this is important because it's astonishing when I think about how. So we have no system in this country to manage drug prices, and as you mentioned the Medicare, which is I think the largest insurance, health insurance in this country, is prevented by federal law from negotiating with the drug companies. This is an astonishingly stupid economic policy. I don't think there's any other way to say it. The VA, the Department of Defense, as you'd mentioned earlier, and Medicaid all negotiate with drug companies.
Now, let me ask you a question. You're talking about traditional Medicare.
Yes, that's correct.
Now what
yes.
about if you have Advantage plan? Can the company you have your Advantage plan, can they negotiate with a drug company for drugs? Let me just give you an example.
Yeah.
CVS has Aetna. That's part of their company. They also have a physicians group called Signify Health, what does in-home exams and home health, etc. They also recently bought out a large physicians group, and they have a healthcare pharmacy benefit plan. So do we know, can they negotiate or can they use their different silos to connect with each other?
I don't know. I don't know specifically how that works. I thought we'd talk about that a little bit later. The combination of a pharmacy benefit, which just complicates it even more, because if they can get a drug on a formulary for a certain price, and the formularies are different than different
Right.
insurance companies, so it's crazy. Nobody knows what's going on.
Right, and different companies have different tiers, which the higher the tier, the more it costs. And if you're on a lower tier, you can almost always get it approved. If it's higher tier, then you cannot get it approved, or it's very hard to get
Now,
it.
the Medicare, the traditional Medicare has a 2% administrative cost. Medicare Advantage has a 15% administrative cost, and I confess I really I haven't quite figured out how all this works. The Medicare Advantage, the way I understand it, is that there's an agreement between the insurance company that's selling this Medicare Advantage plan and the healthcare facility, whether it's a primary care physician's office or a surgery center or whatever. And the goal is that they will so Medicare has a huge database, and they can identify based on the health status and the morbidity of say a group of patients in a practice what it costs to provide their care. So let's say you have a group of seniors and you have a high proportion of people with hypertension, cardiac disease, diabetes, just things like that. So that there's a lot of money there. The insurance company and the healthcare facility then agree that the healthcare facility will attempt to provide the care for this group of patients with an identified financial cost at less than that cost. And if they can do that for less, they can then keep 15% of that. It doesn't go back into the system. If they do it for less with traditional Medicare, it just goes back into the system and then they use it for some other medical cost. That's why they have a very low administrative cost. But with Medicare Advantage, 15% of that is not spent because they're either providing their care more efficiently, or they're just not providing care, or they're doing something called upcoding, which increases the profit ability by, if you code someone who has hypertension as malignant hypertension, you get more money. Or if you code someone with diabetes or pre-diabetes as diabetes, they get more money. So the insurance companies this is what goes on. This is astonishing. But the incentive there is the fact that they're allowed to keep 15% of this as profit, which then the insurance company and the medical facility they agree who gets what or how much.
Well, another interesting thing that's happening is that all the big companies are buying physicians' practice. For example, CVS has bought Oak Street, and they have a practice here in Louisville, don't they? They have two practices here. Now, most of these groups are just seeing Medicare Advantage plans, and so they are managing these patients. And the theory is that if you can keep the patient out of the hospital, can do wellness exams, then you can decrease the cost of the patient care, and therefore they get more money because they contract for a certain amount. If you can provide the care for less than that amount, you make money. The other thing is you just talked about upcoding. Well, they do that in a very shrewd manner. For example, you were talking about diabetes. Now, most physicians in the past have not screened for peripheral vascular disease unless there's a reason for it. For example, if the patient has a pain in their legs when they ambulate, or if they have some other disease that you would think that the patient has peripheral vascular disease. Well, these physicians now are doing either ultrasounds or doing some other type of test to see if the patient has peripheral vascular disease. Well, most people who are in their 80s or 90s will have some form of peripheral vascular disease. If you can do a study that shows that they have minor atherosclerosis of their lower extremities, therefore peripheral vascular disease, they can dramatically increase approximately 40 to 5% the amount of money they get reimbursed. Well, most of these patients are not going to have a problem with their peripheral vascular disease. So and they also add multiple diagnoses to the patient.
Yeah, it's upcoding. Yeah,
Right.
Exactly. Well, let's focus on this now for a little. Let's just talk about private equity and U.S. healthcare for a while.
Okay.
Because basically, what we've got is the wolves of Wall Street are profiting from patient care.
Correct.
Now, so how does that work? Just as a kind of a basic premise, private equity are professional investors,
That's correct.
and their goal is to raise large amounts of money, and they usually get this by having affluent investors, who will reinvest that money in an assortment of ways, seeking the biggest possible profit. I mean, it's very simple.
Right.
They have no healthcare to them is just a vehicle to extract profit. They
Okay.
see it as vulnerable.
Now, there's several different layers to this, which I don't quite understand how it works. For example, there is some companies that are for profit, and then they were bought for an equity by an equity company. So we got a double layer. An example of that is LifePoint, which owns multiple hospitals across the United States. They kind of specialized in rural hospitals. They, 2 or 3 years ago, were bought out by an equity company called Apollo. And so how they mingle those profits, I don't know. Most equity companies have large investors, which includes retirement plans, particularly large retirement plans in California. They come in. The original purpose of these companies outside the medical field was to make them more profitable and then sell them to another company over 5 or 6 years.
Yes, exactly.
But how that works in medical care is totally different.
Well, let's talk about that. So we've got private equity in healthcare, which represents a fundamental conflict of interest between profit and patient care. So the private equity firm will purchase a healthcare facility, nursing home, hospital, healthcare systems, physician practices, outpatient surgery centers, laboratories, imaging facilities, and they buy the non-professional component and, quote, improve efficiency. These is not my words, this is their words. They, quote, improve efficiency, unquote. They anticipate a return on investment of somewhere between 15 to 30% a year, and as you mentioned, they want to sell it for a profit in 3 to 5 years. I mean, this is not meant to be a long, happy marriage. This is come in and take the money and run. So how do they, quote, improve efficiency, unquote? They decrease the staff and increase in nursing homes. They just medicate the patients. They increase the staff and they lay around in bed. I'm going to talk about that again in a little bit more. They encourage the profit-enhancing activities in physician-owned practices like upcoding. They encourage referral to the private equity-owned businesses. And so let me just talk about one aspect of this. 70% of nursing homes in this country are owned by private equity companies, which is really scary.
Very scary.
We were staying with some friends in Arizona, and the woman of this couple was telling us horror stories about one of her relatives in a nursing home up in Wisconsin. There are horror stories, and again, I would challenge our listeners to get online, and you can read about the horror stories in private equity-owned nursing homes. Patients left on toilets, laying in bed with unchanged diapers. And then there was a nursing home in Florida where a patient died from a fecally contaminated decubitus ulcer. Now, for the listener, decubitus ulcer is an ulcer you get on the lower part of your back around your sacrum, basically from laying in bed. It occurs usually in people who have a lot of serious medical problems or are paralyzed and can't move around. So this person was lying in bed, developed this ulcer, and then got contaminated by feces from an unclaimed, unchanged diaper. So the family was understandably unhappy, hired a lawyer to determine some degree of accountability, and they ran into this nightmare corporate structure. One company owned the building.
Right.
One company had the license to run the nursing home. One company provided the professional staff, and the other company provided the custodial staff. And I'm not making this story up. This comes from a New York Times Sunday edition in 2007.
Well,
Mark is telling us we're...
Just to adjust your mic there.
Oh, okay. We're getting close to the end of time, so
Okay,
we may
well,
be running out of things to
believe
talk
it
about.
or not, their nursing homes in Campbellsville, Kentucky, they're structured that way.
Oh, I believe it. There are nursing homes all over the country. And I think it's scary to think about the prospect of having your mother, your grandmother, or one of your relatives in a situation like that, where they're basically just going to be laying around. The story I was told, we were down in Arizona, there was a person having some dementia, and they would just lay food in front of this person. They didn't feed her, and they put some vegetables or stuff, and they would just lay around there. And the family had to come in, and they finally brought some, things like applesauce and things like that. And the person was so hungry it was like feeding. They said it was like feeding a bird. This is a serious issue, and it is a classic example of the conflict of interest between the profit seekers and the ability to provide patient care.
No.
Mark, we're about the end of the lollipop here. Gene, you
2
want to make a
minutes.
few final comments, and I think
While
we'll
we're
end
talking about
today's
equity
session.
companies, there are the two major companies that provide coverage for emergency rooms around the country. They dramatically decreased their costs by hiring PAs or nurse practitioners instead of physicians in the emergency room.
Well, we'll talk more about these issues at another time.
Sure. Okay, guys, a lot of sad but very important information. And I'll just repeat a note that I said a few weeks ago, that the healthcare industry spending on federal lobbying rose 70%. That's 70 from 2000 to 2020. And that's according to new research from the Journal of American Medical Association Health Forum. So it appears the foxes are in the hen house.
They're in the hen house, the farmhouse, and the courthouse.
Yeah, it's. I remember a teacher told me once, people do what you inspect and not what you expect. And with regularity, there's inspection of the Medicare Advantage program, and with those inspections of the program, there's more and more fraud discovered.
Yes.
If you really interested in the greed in healthcare, there's a fascinating article in the JAMA, which stands for the Journal of the American Medical Association. It's only about a 2-page article, but it talks about the existential threat of greed in the United States healthcare system.
Yeah.
Well, that's a good place to end.
Yeah. For more information about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org. You can email our chairperson, Kay Tello, at nursenpo@aol.com. The group, we stretch from eastern Kentucky to western Kentucky. Most of us are based here in Louisville. Kay sends out a newsletter twice a month. It's just jam-packed with information about how you can become involved with the group and take your frustrations with the system and put it into action. Kay and the group have some good projects that are cooking right now. One of the ideas was getting some referendums on local and in local communities to pass Medicare for all referendums for single-payer health care. And Doctors Mike Flynn and Gene Shively, I'm Mark McKinley. Thanks for listening.